Good afternoon, ladies and gentlemen. Welcome to this webinar to look at the government's recent white paper on health and social care reform. We've ambitiously given it the title, Delivering for Patients, an NHS and Social Care Revolution in England. Delivering for patients. Will it or will it not? Is this going to be a politically driven process, a finance driven process, a provider driven process, or will it truly put patients at the heart of NHS structures, systems, and decision making? We have 250 plus people registered for this webinar today, so we are not turning everybody's microphones on. If you would like to submit a question when we get to that stage, or even before, if you could paste it in the chat room, the team will then draw my attention to it and we'll get round to you. We're particularly delighted that we have members from both houses of Parliament and all political parties joining us. We have one former health secretary joining us and two health ministers, which shows the impact and the importance of the subject that we're going to be looking at. We're going to be joined, we are joined, in fact, by three experts in this policy area. Sharon Brennan, a senior correspondent with Health Service Journal, which I'm sure you will all agree with me is the absolute must read every morning when it pings into your inbox. We're grateful to have the opportunity of Sharon's analysis and to hear all the behind the scenes goss that she's no doubt better than us at getting hold of. We have David Hare, Chief Executive of the Independent Healthcare Providers Network, who is, I am proud to say, a former Whitehouse consultancy staffer. Indeed, he was my number two for many years. We also have Robert Eade from Policy Exchange, where he heads their health and social care policy team. Rob, too, is a former Whitehouse alumni. We attract the best, develop them, and then they get headhunted for jobs elsewhere. But nevertheless, in the time they were with us, they made a very valuable contribution to the Whitehouse consultancies team. We're going to kick off with one question at least from me so that the speakers can map out their initial views, and we want to get to audience questions as soon as we can. So without further ado, I'm going to ask of each of our colleagues the question, what are the reforms that are needed to put patients first, and does the white paper deliver them? Perhaps Robert, you could kick off.
Thanks a lot, Chris, and thank you for inviting me on to discuss this really important issue. It's an excellent starting question because I think often there is a temptation to obsess about the structures of the NHS when in reality the people that are often least impacted by reorganisations are frontline clinicians and the patients that are looked after by them. So it's really important, I think, to ask that question around the impact that this will have on patient care. And I wanted to make three observations from our perspective at Policy Exchange. So my first observation is around the role of patient voice and accountability in the new structures. So there's been a substantial debate around whether the new ICS system will dilute the patient voice. And I think that risk is quite genuine. So much of the new structure has been left to local discretion. There's an understandable rationale for that. They are favouring place-based approaches. But there's a worry that the kind of two structures that you have with an ICS board and then an ICS health and care partnership will mean that the patient voice involvement is only given a sort of small element, probably sitting within the health and care partnership. Whatever your views of the 2012 Health and Social Care Act, Andrew Lansley really wanted to put patient centricity at the centre of those reforms. His view was that patients should be able to vote with their feet. If they didn't like the provider where they could get a procedure done, they were entitled to seek support or to get that treatment done elsewhere. The white paper does imply that patient choice will be upheld, but there's a broader concern, which people like National Voices have outlined, that their seat at the table when wider decisions around commissioning are taken won't be clear. My second concern is the trade-offs that come with any healthcare legislation. So it is possible for these reforms to benefit one set of patients, but not another. So, for example, will the new legislation make it easier for someone with complex mental health needs to receive coordinated care? Yes, it should. But does it make it more likely that a patient requiring, say, a routine cataract surgery appointment will get treated as quickly as possible? That is potentially less clear. Under the previous system, high volume activity was rewarded. And as Jeremy Hunt has said, that was kind of a system set up back in an era where the biggest political concerns were waiting times for elective surgery. Well, fast forward a decade or so, and we find ourselves in a situation where the government is facing quite a lot of political pressure over a large waiting list. So have we got the right mechanisms to deal with those political pressure points? That's going to be a trade-off, I think, with both within the NHS and also at a political level. Kind of with the evidence from longer studies, for example, I think the Health Foundation has done some work in this area, are that integration takes quite a long time to pay off. You have to be really patient to see the benefits of some of these new models of care. Do we have the right level of patience within our political system to accept that when we all have a very significant waiting list? So I think that's one of the tensions. But finally, I wanted to end on an optimistic note. So this white paper has been a long time coming. The seeds were sown in the 5-year forward view, which was a 2014 document. And so it's been kind of 7 years or so in the making. And that means that there is a genuine broad consensus from our perception of the benefits of this legislation. We've also had the benefit of seeing some organisations operate in shadow form. So I had a call earlier this week with a provider collaborative in the West Midlands who deals with obesity and also with eating disorder approaches. And they've had around 40 patients who are now housed within the West Midlands thanks to a new provider collaborative, rather than having to be housed outside of the area, in many cases in completely different parts of England. So the benefits of a provider collaborative have started to be realised. And so that is of clear benefit to the patient to be treated closer to their home. So there are positive signals already. And I think that means that we can step into this legislation with a higher degree of confidence that the plumbing may work compared to, say, 2012, where there was more uncertainty. And with that, I'll close.
You're on mute, Chair.
David, what's your perspective?
I assumed you said that, Chair. Just to thank you and colleagues for the invitation to today's session, very timely. Obviously when you look at the white paper and read the accompanying documentation, including the consultation on the provider selection regime, I don't think anyone should be too surprised by the direction of travel set out in the white paper. This has been long trailed and frankly largely as a way the NHS has been working for some time. The key litmus test for it really, and one can overstate the impact of legislation, is will it lead to a more coordinated, a phrase I prefer than integrated to be honest, but a more coordinated healthcare system, reduction of duplication, fragmentation, whilst maintaining a responsive service. And I think, we should come at it from that perspective. And you're right, Chris, I think to set the scene in terms of whether or not it will improve services for patients. Equally, I don't think we should be too surprised by some of the elements that are perhaps attracting a little bit more contentious political interest, particularly the role of the Secretary of State. I remember in the debate around the 2012 Act, huge concerns across all parties actually around pushing sort of out Secretary of State responsibilities into NHS England. And given the fact that the buck often stops at Secretary of State for Health's door, I don't think we should be too surprised that perhaps they want to take some of that back. And it'll be interesting to see how that debate plays out, given many of the figures who were around back in 2012 will be key, I suspect, in debating this moving forward. I think for me, there are probably three key tensions that I see in the white paper that we will be following pretty closely. So the first, and Rob touched on this, is that I think over the course of the next several years, the two big topics for political and public debate around the NHS will be access. The numbers on that are absolutely heart-stopping, and we see the January figures will be out tomorrow. We've gone from just over 1,000 long waiters in February 2020 to nearly 250,000 now, 225,000 on the last estimates. I suspect in reality we're probably nudging 300,000 So huge growth there, and the number of people waiting over 26 weeks has grown materially as well. And given the impact of this winter and the pressures on the service and the pretty widespread cancellation of electives, I think access is going to be the big ticket issue for the next period of time, and largely the legislation and the white paper is silent on access. The other one, of course, is workforce. We have huge problems in terms of the healthcare workforce in this country, and that will become a even bigger issue as we move through the next few months. And I think you've got a tension there between sort of headline legislation that is quite a technocratic exercise actually, and what the public will be looking for, which is a well-staffed, well-resourced NHS with good levels of access. So that's the first tension. I think the second tension is between the laudable quest for integration or coordination with the danger of cosy monopolies. Quite late in the day, the introduction of the phraseology of the purchaser provider split will be retained, but actually when you scratch away at it, there is a real danger that actually decision making in the service will be very provider led, and there is a real danger of conflicts of interest, which will need, parliamentarians will no doubt want to look at very closely. We always have a little bit of a pendulum on these issues, and possibly post the 2012 Act and the kind of criticisms of competition and market madness and so on. I think there's potential danger that it goes too far the other way, and the public do need to have a responsive service that has a degree of consumer-led processes around it. And then I think the third tension, a bit of a watch out, is very unusually this legislation and the white paper is being presented as this is what the NHS wants. That's quite a hard thing to sustain in terms of determining precisely what it is the NHS itself wants. NHS England done a good job, I think, of consulting quite widely, but legislation, as we know from history, can get quite contentious and rancorous rather quickly, and holding to the line that this is what the NHS wants is quite a curious way of going about developing legislation. You wouldn't imagine that in other public services to be the way in which it gets framed. So, I think overall there's some element to be welcomed in the white paper and the subsequent legislation, but I do think there are some pretty key tensions that people will want to be watching out for as the debate ensues when the bill gets presented, probably in about May. So I'll close there, Chris.
Thanks, David. Yes, we're expecting the Queen's speech on and around a date in May that is the 18th, Tuesday the 18th is what the hip-off is. No doubt there'll be a big bill in there, but of course the government did leak that it's planning another white paper on social care reform towards the end of the year. So that bill could have an interesting journey, starting off perhaps in the Commons dealing with the initial reform and then being amended in line with the second white paper in the House of Lords. That would seem a logical legislative vehicle. But Sharon, what's your view on this? What are you hearing behind the scenes?
I think if you think about what patients actually want from an NHS, they want to be treated within a reasonable time frame. I think they appreciate that an NHS as a taxpayer funded free at the point of access means that you may wait longer than in some other countries, but they want to be treated within a reasonable time. They want fair access and they want safe care. And I think a lot of the white paper that in terms of the change of the government's, the removal of CCGs, the creation of ICSs, none of this will matter to the average person on the street. And to be honest, I wouldn't even expect them to understand it nor have an interest in doing so. But if you look at those issues, I think what was interesting yesterday, Simon Stevens appeared for the Health Select Committee. Jeremy Hunt asked him as the chair of that committee, is this the right time for this paper? And he said, given the COVID recovery, and he said, yes, because we've been working on these reforms for 7 years. So it's basically filling off 1/10. There's 1/10 left of the reforms to do, and that's what we need legislation for. So he was very clear that this wouldn't push back or complicate any further COVID recovery. I think it's essential that it doesn't. Coming out this year, as David and Robert pointed out, the waiting lists are immense, and that's what people will be caring about. They won't care about how you organise something. But beneath the organisation, there is something that I think David and Robert have both mentioned. There's a concern, I think it could move back to the old PCTs that existed before the CCGs. And I think with the PCTs, a big concern was, again, the idea of monopoly, marking your own homework. And as much as a commissioner-provider split was seen as a frustration, and you did hear Stephen speaking yesterday of the need to retender the entire national specialised commission services. And he said at the time, who's going to be the new Royal Marsden? There isn't going to be a replacement. So as much as that was frustrating, and I think rightly should be pared down, it did give you some concept of grip in the system. There was an idea of a commissioner holding a provider to account on what are they doing, what we're paying them to do. And alongside that, there was a concept of quality and whether what's being provided is reasonable. and is of decent quality. So I think they're the areas where the white paper leaves questions to be answered. I also think there's something quite interesting around regulation and how you make sure that something is safe. Simon, as if I'm on the first name gentleman, Sir Simon mentioned yesterday, there's a bit of an ongoing tension at the moment in the Northwest, where Matt Hancock has written to a Lancashire teaching hospital and told them that their Chorley A&E closure can't go ahead because he wants it to be seen in the round of an ICS. Apart from that, that seems to be jumping the gun slightly on the powers that he wants in his paper. Stephen's actually said, well, if a CQC says a system is unsafe, so in this scenario, they knew that Chorley A&E is unsafe, it can't get the staff in, then it should be very clear who holds that decision. So in a way, he was basically saying if Secretary of State wants these additional powers, he has to accept that he therefore has to take responsibility for the safety or lack of those changes. And I think there is something there about how you ensure that safety remains within the new system that I don't think has been thought through very well. And then again, finally, on the waiting list idea, we've been discussing this since November within HSJ. There is an idea that an integrated care system would pool all their waiting lists across a region. As the theoretical idea, it's actually very good. I mean, why should someone in Reading wait longer for a hip operation than someone in Oxford? Practically, it's very hard to do. It's kind of based on finance flow and the ability to manage that kind of waiting list. So, but I do think there is an idea here of trying to equal out care within an ICS that maybe wasn't there in the 2012 paper. I know, Robert, you referred to the idea of voting with their feet, and that was the idea that Lansley had, that you could just choose to go elsewhere if your provider wasn't very good. I think that was fairly disingenuous, and looking at the inequality that's come to the fore in COVID, I think voting with your feet is very much a middle class thing where you can afford the transport, you can afford to take time off work, and you've got people that can continue to care for your children, etc. if you're accessing care quite remotely. And I don't think that was ever going to work as an equal kind of for people to gain equal quality. So I'm kind of glad that that's changed. But I do think, as other people have said, there is quite a lot of questions in this paper about how you ensure fair access, how you ensure safety, and how you ensure that quality is maintained. And I think on that, we'll go over to questions. But yeah, I think there's quite a bit to debate.
Thank you very much, Sharon, for that contribution. A couple of speakers have mentioned workforce issues and the attitudes of those who are employed by the NHS. Interestingly, our next webinar in this series on Tuesday, the 16th of March, will be on the people plan with Virgin Care, amongst many other senior participants. But I've also had two questions in from Lord Hunt, a former health minister under the Tony Blair government. So let's take those. Perhaps, David, you could come first on this one. I find the local arrangements in the white paper very confusing, and Philip, you're not the only one. In particular, I can't see who will be accountable locally for the whole system working re-health and social care. And he goes on to ask, how best can you integrate care when you have different funding streams, one of which is means tested?
So, Lord Hunt, you're not alone, I think, in perhaps being a little confused in in how the local accountability measures will work. I think when NHS England originally consulted, seemed a long time ago now, on these proposals, there was a question really of should the integrated care system be put on a statutory footing or not? Should they sort of remain in effect voluntary groups? I'm actually quite pleased that they are now proposing they be on a statutory footing, because that at least gives some hope that there is a bit of clarity over who is in charge of the system. I think it's Andrew Adonis many years ago said there are no statues of committees, and there's a reason for that. And actually there was a danger with the ICSs that sort of everyone was in charge, but nobody's in charge. I still think we need to do a lot more work on the governance of those bodies, what the decision making looks like. I think fundamentally the public in any area need to know where they can go to if they've got concerns and problems, and I don't think as they are currently constructed it's particularly easy to work that out. It's not perfect now, by the way, but equally I think it's potentially even more confusing. And then I think there is that point there around the benefits of the purchase of provider split. It is much maligned and has been criticised over the years, but the alternative is potentially just very unresponsive, hazy healthcare, and I think we've absolutely got to avoid that. In terms of the link with social care, funding, of course, is but one of many illustrations of why one of the many reasons why it is quite difficult to bring the two things together, commissioned by different entities, quite different services, and I think there is a bit of a danger with these proposals that the way in which social care and local authorities are brought in are on the NHS's terms, and culturally that often lands quite well, frankly. Quite badly, I've found over the years with colleagues on the other side of the aisle. So I think this is an area that's going to need a lot more debate and discussion as the legislation works through, I think.
Thanks, David. Sharon, do you want to pick up on that and add a few words of wisdom?
I think one of the idea of, I think they need to get legislated. I think partly because the Treasury was just not going to accept that the money goes to a non-statutory board. At the moment, funding flows to a nominated CCG within an ICS, and they hold the money. That was never going to continue, and I know the Treasury was very focused that they needed a clear line of accountability. So in that sense, it's good. There is a concern of where the buck stops. For example, there was no mention of this Care Quality Commission changing its regulations to allow it to do carry out fit and proper person tests of the chair and the chief exec of an ICS. I would expect that to have to change if they're going to be in charge of so much money. And then also we do know that the idea of the second board, the Health and Care Partnership Board, was added very late. Stevens himself said yesterday that he changed his mind on it, and it was very much lobbied from the local government association that should exist. And I think you can tell it's been added very late because while the ICS NHS body, as they now call it, there's a clear pattern for that. They've been STPs and current ICSs have been asked to set those up anyway. So we clearly know what they look like. There's already work beginning on how they would work together. So we know the mandated, the legislation makes very clear who should be sitting on those boards. It refuses to make any comment on who should sit on the HCP boards. And it's very unclear who holds the power. Is the HCP going to have more power than the NHS ICS body? Who's going to win if there's an argument over money? I mean, you can tell it's been added in late because there is no discussion on that. And I think you could end up the NHS just getting on with what it wants to get on with via its ICS board and paying some lip service to the HCP, which I know someone's just come through on the question and said, this is meant to be about social care as well. How does that fit in? So it will fit in via the HCP, but we don't know what powers it has. We don't know who should be sitting on it, and we don't know how the two integrate. So totally agree with David. Very unclear where the authority sits. And then just to add something extra, a lot of the work and integration takes place at something called place level, very frustratingly named because it kind of very woolly. There was a decision to not legislate for that area, which I think most people agree with. But who holds the money at place level? So there's a discussion that ICSs will have money, they will pass it down to kind of a smaller area of people where they can make decisions for more of a local area. But who will hold that money? Who's accountable there? Who sits on those boards? Who shouldn't be involved? Who should be involved? I mean, when it comes to accountability, I think it's definitely lacking in the white paper. That's probably one of the biggest concerns looking at it.
Thank you, Sharon. Rob, do you want to add to that at all?
I think the only thing that I would add is the issues around ensuring that the boundaries are correct, which kind of links back to Sharon's point around place-based approaches. It's something that came up in the session yesterday where Amanda Pritchard was actually asked by some MPs for her view about whether they should ensure that all of the boundaries for the new ICS footprints are consistent with local authorities. And realistically, that will need to happen if you are going to have better shared working. So if the ambitions around better integration of social care and health are to be achieved, that needs to happen. But as you can see in places like Essex and down in Bristol, that is not the case at the moment, and it is causing major fractions. So that all of that element still needs to be worked through, and I think that's something for the passage of legislation to kind of smoke out, hopefully.
Can I just come in on that issue of boundaries as well? We have at HSJ, we've been understanding that the issue in Essex, so Essex County Council is split into 3 separate ICSs. No one in the NHS seems to want that to change, and the main driver behind it seems to be Matt Hancock. And I think the problem we've heard, we've got this on record from the Southend Council who were talking about it, saying he cannot focus as a group on cancer recovery and mental health recovery if they now have to run around trying to renegotiate their ICS relationships, who they should be sitting with and how that will work together. And I think that idea of boundary change is coming way too early. Like, you need to let people come out of COVID recovery, focus on getting those waiting lists down and then look again. And Hancock's very, very focused in Essex, especially on trying to get that changed. Also, Frimley ICS is likely to disappear entirely because it doesn't actually align with a single council whatsoever. And that is, you know, one of the original ICSs. It does a great job. It's a very successful area. We may get rid of it entirely. So we have these coterminous boundaries. And I think this is when it starts to become much more of a kind of 2012 Lansley issue where you're throwing everything up in the air and redrawing things. Because is that going to help patient care? No, not in the next year or two. You need to just get on with, you know, focusing on letting people get on the waiting list. And redrawing boundaries now is, in my opinion, the wrong thing to do. But it seems writings on the wall for the Essex one. I don't know about the other areas that they can fight back. But notably, Simon Stevens said yesterday that he was largely in agreement. He didn't want it to go into the legislation, which I think is his way of saying, hopefully we can just ignore this in a year's time.
Wouldn't be the first time. Coming as I do from a local government background, I'm with some of the people in our chat room that I think that it would be a tragedy if government missed this opportunity to sort social care, to move it up the agenda and to ensure that it can play its full role in avoiding admissions to the health service in the first place and to facilitating returns back to the community. That's got to be in everybody's interests, particularly patients and ultimately the fund holders, because it's more cost effective to keep people out of some of our great hospitals than to put them in. David, I know you come at this from a private sector perspective, but you know, what's the finger on the pulse amongst your members about how they could step up in social care? And do you think the white paper opportunity will be seized to actually deliver on the DHSC title?
History would suggest probably not. I'm afraid. I think you know, I think what all of us on the panel have described in terms of the white paper and the legislation, most of the legislation anyway, is it's a pretty technocratic NHS exercise. Actually, I don't think, you know, Sharon quite rightly argued, and I completely agree with it, that most of the public won't have a clue what most of these acronyms are and the varying sort of groups that are being brought together. But it does feel quite an NHS and frankly public sector led process, if I'm honest. There are some learnings. I think, you know, when you look at places like South West Yorkshire and the work that Rob Webster has done in his ICS, actually he's done a great job of bringing in a quite wide range of providers of partners, and they've really established a good way of working. I think that's been done pretty well bottom up. Yeah, but you know, I sort of come back to this sort of sense that you've got an NHS white paper. Government's been pretty silent really on social care. There's a suggestion of sort of social care proposals maybe later this year, maybe next. But let's be honest, we've been talking about this for so long that, you know, it's a bit like waiting for Godot, isn't it, really? So, you know, I'm not hugely confident that this time it will be different. I'd like to be proved wrong, but I'm not hugely confident.
Rob, what do you think about that?
Yeah, I think unfortunately it is becoming a bit of a case study in the failure to manage people's expectations. People are continuing to play back Boris Johnson's opening remarks when he first arrived at Downing Street as Prime Minister. And I think that could end up haunting the Conservative Party as they look to the next general election in 2024. And so there is a realisation that something needs to happen. I think, you know, as Policy Exchange, like traditionally a think tank that's associated with the centre-right, we have said that there needs to be a big and comprehensive offer around funding reform, and we've done quite a lot of advocacy in this space. We think that it should be funded through general taxation, and we've partnered with IPPR to offer kind of a bipartisan endorsement of finding a funding solution. Whether that would consequently lead to an attempt to pull budgets around health and social care, I think we wouldn't take a strong view on that. I mean, it feels logistically very, very difficult. And I think there's sometimes the temptation to draw the map, to use the kind of Sharon's analogy about boundary reform, and to imagine the world as you want it to be, when what is realistically possible and what difference can be made for patients might actually be a little bit more modest. I think there's also a lesson bringing these legislative proposals forward for the NHS, and David was right to say that the key line they are using at the moment is the NHS have asked for it, but it only just highlights the inaction on social care, and so it does open their flank to criticism. By doing something in one area, your lack of activity is exposed in another. So I think that's something to think about, and could be an interesting line for the Labour Party and other opposition parties as the bill comes forward.
Sharon?
I think there is something very interesting there that you talked initially about discharges, which are already slowing down again. I mean, in COVID, in the first few months, people were saying to me that, you know, you couldn't actually arrange a discharge until all the medicine the patient needed was within the ward, because people were leaving that ward within an hour. I mean, that was a utopia. It's now significantly slowed down. We've seen the reintroduction of a specialist healthcare fund called NHS Continuing Healthcare. People argue over that all the time. It creates schisms between local authorities and the NHS over who should be paying for that person's care. And that slowed down discharges. We've seen a very unstable care market. One of HC1 is selling out 52 of its care homes, so it's no longer viable. And when you lose the big providers in areas, what you generally are left with is a smaller family-run businesses, and invariably they're in the much more deprived areas. So in those areas, you're really struggling to discharge because either they feel too fearful to take on COVID-positive patients, they can't get the insurance, and bearing in mind the government's, you know, insurance indemnity offer to cover that concern runs out by the end of the month, or they're too small to keep going. They don't have the finances behind them to manage what we've seen as a significant reduction in residents since COVID hit. So I think the actual big concern in social care, it's not about discharges, because they do want to help with discharges, but what they actually want to get back to doing is some of the stuff they wanted to do all along, which is prevention. And I think the problem with the money is that you argue again and again, it has to be prioritised in discharges. We'll see that again. The waiting list has to be got through. You can only get through the waiting list if you have spare beds. You can only have spare beds if you can get the discharge sorted. So yeah, yet again, we will focus on that. And what we're not focusing on is the stuff that would actually save money, but, you know, years down the line, which is prevention. How to prevent older people from falling in their homes and needing an emergency admission, and normally years of social care afterwards. How to prevent people with long-term conditions having their conditions run out of control and turn up in A&E again, you know, with a severe exacerbation. That is heavy, long-term work that social care is very good at. And I should think they won't have the money to even think about doing it this year, because I think The Guardian this morning said that 29 councils are on the verge of going bankrupt. So yeah, it's a huge failure. I was quite surprised that Rishi Sunak on Radio 4 the other week was saying he wanted a cross-party consensus for social care. Boris has a massive majority. I don't know why he's not using it.
I think that's a fair point. I think one of the challenges for social care is that it just doesn't have the voice in the national policy debate that it merits, given the scale of the operation and the value that it's delivering. But you mentioned prevention there, and I talked about keeping people out of hospital earlier. Public health. You had a columnist in Health Service Journal only the other day saying that public health should actually be taken off local authorities and given to the NHS to lead on. What's your thinking on that? I know that's not HSJ policy or anything.
So that policy, the idea I think is that the NHS believes they can get more power behind it, get more regular money behind it, and help situations, things like social school nurses in nurses in schools, HIV, sexual health policy, addiction, that kind of area. And historically, the NHS has actually been run out of these areas because they tendered, the contracts that were tendered, they gave a realistic cost for how they felt they could run that services were undermined, and you know, the council chose the lowest cost service because of their budgetary concerns. So I think that's, you know, the NHS has a clear argument on that. They want it back. We obviously have PHE closing, and there are some elements of Public Health England that need a home, such as those issues I've just discussed. As soon as that opinion piece came out, I had a lot of people from councils going, this is the wrong thing to do. And I think maybe you could see it as a joint initiative. You could use these integrated care systems and actually see what can the NHS do and what can social care do, and come together on some of that work through pooled budgets. The problem with this, and going back to someone just raised about West Yorkshire, you have amazing ICSs. West Yorkshire's always raised, Rob Webster's always raised. He will probably do very well at this kind of thing. He's got the relationships there. He can probably do a lot of this kind of integrated pooled budget work. Where those ICSs aren't developed and the relationships aren't very good, legislation is not going to help with any of that. It will force them to come together, but it won't force them to like each other. So I think you could end up with quite a patchy system where public health is good in some areas and not in others. And also, just to add to that, there has still not been any public health settlement. So we're about 3 weeks away from the 1st of April, and they still don't know what their public health grant's going to be. So how they can possibly plan for this work, I don't know. And I think that's partly why the NHS wanted it, because they do get better warning on what money is coming. So maybe they feel they could plan slightly better and take that concern away from councils. But I can tell you now, if you take it away from councils, there's going to be a huge row.
Yep, and as I say, coming from the local government background, I think public health has a great job to do. Social care's got a great job to do. Paediatric public health and social care in particular. The earlier in the development of a child we can identify a problem, we can identify it, we can intervene in it, and we can impact on the outcomes. So it's short-sighted to cut the early intervention strategy. We should be putting a lot more there, and that's my message to Matt Hancock and Rishi Sunak. But Rob, what about you and public health? Where do you stand on this?
Policy Exchange did put out a report around 5 or 6 months ago, which looked at some of the potential changes that you might need to see in the structures of public health after the Secretary of State announced the decision to create the new National Institute for Health Protection, which he made that speech at Policy Exchange. So we wanted to provide some kind of practical suggestions, and I think our starting point was looking at the government's manifesto commitment to add 5 more years of healthy life by 2035. It's a really ambitious claim. I think it began in the 2017 industrial strategy, so it's kind of a hanger on from the Theresa May era. But there's no concrete plan around how you can actually get to that. And if anything, if you look at the statistics around healthy life years, they are actually in decline, and particularly amongst women, where there is a much more severe decline. So the proportion of years that you spend in healthy life, I think, has gone down by a kind of year or so since 2010. So action is needed, and they need to come up with a concrete plan. I think my worry about splitting the sort of different bits of health improvement that aren't going to be part of the new Health Protection Institute is that you end up with no clear voice for them within government. And so often they've struggled because they've been outgunned. I mean, even PHE is a small organisation with quite a minimal total annual running cost, and it struggled to get much of a say despite being an executive agency. So I think, well, I would encourage those in Downing Street and within the Department of Health to find a way of kind of putting rocket boosters under that agenda, whether it needs to be a particular unit within the Cabinet Office or given additional responsibilities. I think they need to be prepared to get creative.
David, does the private sector have a role in public health? And if so, how does the white paper impact it?
It's probably got one of the biggest roles to play in public health, insofar as when you look at the sort of broad sweep of kind of services that people receive in terms of the broad public health measures. You know, the vast majority of that will be private sector as well as voluntary sector, a little bit of public sector, but you know, even things like, you know, gyms and exercise and so on is likely to be driven by the private sector. I think, you know, the frustration I have when you sort of see the debate about should public health sit with local government or NHS, you know, go back to the 2012 Act, where it transferred from one to t'other, and then nearly 10 years on, we're talking about transferring it back the other way again. I mean, is that the limit of our aspiration, you know, when it comes to public health? It's hard yards, this. It's difficult stuff. And I think we also have to acknowledge the last 12 months have been really quite bad for public health. You know, there's been a phenomenal response by the NHS with a particular focus on acute-based care, but we will be storing up huge numbers of problems as a consequence of what's happened over the course of the last 12 months. And you know, there is an absence of clear direction and a clear plan around that. So, you know, you could ask a question of, do you need that? You know, do you actually need a sort of national top-down plan, or actually is this better done locally? Open question. But yes, absolutely, the private sector's got a key role to play here. It does do that, and can we stop fixating on who has responsibility for budgets? Because I'm not sure that helps anybody really.
It helps a little man with a clipboard in the Treasury who likes to know who to blame when it goes wrong. But just picking up on what you said there, David, and some comments in the chat room, which I think are very valid. It's the diversity of providers in English healthcare is actually encouraging. Now, of course, some of them are great at the job, some of them are less great at the job, but there is a diversity out there which has been flourishing in recent years. What about the voluntary sector? What about the third sector? Is it right that NHS, social care and public health should rely on them so much, or is that a good thing?
I think you look at any industry, don't you? And in effect, it's the management of complex supply chains. You know, whatever industry you're looking at, health and social care is no different. I don't think you know, we're ever going to come to a place where all of health and social care in a particular part of the country is run by one single public sector organisation. I don't think anyone would want that. I don't think that's likely. So therefore, the exam question is, how do you coordinate all of those bodies in a way where everyone's clear what they're doing, the incentives are aligned, and the funding flows work properly? And there's an opportunity, I think, with the white paper and the legislation, possibly to stitch that together in a way that we haven't done previously. But equally, culture gets in the way of this, I think, often. Sort of public sector first mindset can pervade. And whenever we talk about diversity of provision, you're not too far away from the privatisation argument, and that just stops anybody making any progress. And actually, all that ends up doing is causing the one big divide in healthcare, which is between those that can afford to pay versus those that utilise the NHS. So, absolutely. Priority of provision is crucial. I've seen how can the voluntary and community sector in particular have a voice at the table. Hopefully the partnership boards will help with that. But equally, we need a bit of a shift in culture, which says, how do we coordinate everybody together in a shared endeavour in a system, whether their paycheck comes from a voluntary organisation, a private one, or a public one?
Rob, an opportunity to provide us together. How do you see that?
I mean, I would echo a lot of what David said. The NHS cannot do this alone, and that was probably the case before the pandemic, but it's just further accentuated it. At the start, in one of the opening remarks, talked about staffing shortages, and those are exceptionally acute within the health service. So I think they are going to need to think about working with a range of different partners, and that is not just the independent sector, but it's also thinking about the voluntary sector, which regrettably has been massively depleted by the pandemic. If you look at how they've been able to generate revenue, that's been severely impacted by the changes that we've seen as a result of lockdown, etc., and not necessarily a huge amount of government support to keep all of those organisations afloat. So I think regrettably you may have a situation where the NHS is asking for help and the voluntary sector and to some extent the independent sector can't necessarily meet that expectation in demand. That opens another conversation about how you kind of build up the resilience of the healthcare system on a more permanent basis, but that will take time and is, it comes at significant cost. And I think it will be an important economic debate around what the appropriate level of long-term increasing capacity in the health service looks like. For example, around bed numbers, I think there'll be a big debate around what proportion of beds we want to have in 5 or 10 years' time to potentially avoid situations like we had with field hospitals being kind of erected this time in response to the pandemic in March.
Sharon, any thoughts on this?
I think I'd agree with Robert. I mean, the main concern about involving charities is that involving charities when this legislation was first considered, so obviously this has been under debate for a couple of years, and involving charities now post-COVID is a completely different scenario. I've heard from lots of charities where, they specifically suffered because they weren't allowed to use, I think one of the big regrets when you look back is that when the Treasury furloughed staff, they didn't allow charities to actually use those staff. Because what we've seen is a huge increase in people seeking help from charities about COVID, about concerns they've got, and very few people able to answer them. We've seen hospices not being able to cope and have to get cash injections from the government. I mean, I'm very clearly hearing now that hospices are actually using this as kind of a reckoning moment and saying, why are we funding 2/3 of essential care through marathon runs and bucket chugging outside supermarkets? And I think, again, the same issue, I had someone come to me saying there was concerns about trying to keep the Child's Air Ambulance in the air because we are the only country that funds that as a charity. Why don't we have air ambulances that work as part of the NHS? So I think there will be a rethink here of what should be funded and what shouldn't be funded. That doesn't mean to say that it shouldn't be run through a charity, but it means to say that some of that funding should maybe be, what we expect of charities should maybe be funded. So if we're asking charities to basically be the first point of call for concerns about diabetes and therefore taking a huge weight off regular calls into GPs or diabetes nurses, how are we paying for that? And I think that's going to have to be looked at, because if charities kind of carried on with the status quo because they could, now the money's gone and fundraising is much harder. I think now's probably the time you're going to have quite a lot of questions saying, well, if you want us to be part of an ICS and you want to rely on us, then we have to have consistent funding. So we're here next year and the year after and the year after to be here to be part of those plans.
Yeah, thanks for that. Two interesting points in there. Just by coincidence, you mentioned hospices and how they're struggling. On our audience today, we have Professor Baroness Elora Finlay, who is a world leader in palliative medicine in the hospice movement. So maybe she might have more to say through your columns at some point, if you were to invite her to do so. And you touched upon the Children's Air Ambulance. You're absolutely right. They're a former Whitehouse client. They are really struggling. The charity shops, which were one of their biggest sources of income, are closed, and they can have no confidence about when they are reopening. So that mix in the economy is missing a leg or two as a table. It's not stable as a result of pandemic, in my view. And in fact, local authority contracts to third sector people are very valuable now, of course, to the third sector, because their voluntary income has gone. But can I come to you again, Sharon, with a question just to ask, what are you hearing behind the scenes Labour's approach to this white paper will be? How is it going to try and turn it to its advantage? Are we going to have another round of everything reduced to the absolute minimum of the terrible Tories are trying to privatise the NHS through the back door? Or is there any prospect of getting Labour into a constructive discussion during the passage of this bill, how it can make a good bill better, quote a member of the House of Lords in another legislative environment? I mean, is there any hope of a genuine constructive national debate revitalising social care and integrating it with the NHS?
So I'm hearing very little. I think, I think Labour's quite quiet on quite a few things at the moment that you would expect to be making more of a noise about. The ICS, the bill actually has an opportunity to be criticised without criticising the NHS, because as Simon Stevens said, 85% of it is, was asked for by the NHS, at least 15% that wasn't, and they are the much more worrying things. And I think what you will find at the end of this bill, and I would expect some opposition to decide, is the powers that Matt Hancock's seeking are quite sweeping. They have no caveats and they have no checks and balances. And I would expect something to be put in place there, especially around local reconfigurations, where he wants to basically say yes or no to reconfiguration very early on, and potentially around some of the other areas where it appears to be that he could just axe NHS England as and when he or his or her predecessor decides. So I'd expect some opposition around that. On social care, someone has to just be brave enough to say, what are we going to do? I mean, it's obviously going to involve money. One of the concerns I have as someone who has had multiple health problems myself in the past is the social care debate still continues to be around older people. It doesn't discuss what happens if you're working age. What happens if you're working age and you're looking after your partner and your partner unfortunately dies? Are you therefore going to have to sell your house? Or is a local council going to basically have your, be owed a bill for 30 years until you can pay them back? I mean, the debate's already skewed. I'm amazed that no one's yet come out and said, well, this is, to be brave enough and say, this is what we're going to do. I don't think the Labour Party is going to do it, because I don't think Boris Johnson is going to do it. But as it stands, we are watching social care collapse. And it will basically, NHS will pick up the bill, and we will see more people going in with falls. We'll see more people who turn up in A&E who haven't been cared for. And that's basically because people can't afford to pay for their own care and don't meet the increasingly high criteria. So I haven't heard much from Labour. Maybe Robert can help a bit, as he might know more behind the background, but I think they've been quite quiet and they're just waiting to see how this plays out. But, the public don't care about reconfiguration. They just care about safety, access, and equality of access. But yeah, maybe Robert can help a bit more on the Labour quietness.
Well, it seems I'd better come to you then, Robert, to find out what David Cameron's favourite think tank thinks about Labour's position.
Yes, gosh. One thing I would perhaps say to politely disagree with some of Sharon's comments about the 15% is, I think that of the proposals which are, I guess, proposed exclusively by the department, so weren't asked for explicitly by NHS England, there are a number which I think Jonathan Ashworth privately will be quite supportive of, and he will see Matt Hancock when they're in Parliament in the voting lobbies, and he will say, yeah, I think that's actually quite a sensible suggestion. And the ones that I specifically would point out would be around the mandate. So the NHS Annual Mandate, which is this kind of letter, 7-page letter that's sent from the Secretary of State to outline the priorities tied to the financial year, no one really takes any interest of that document. It has very little impact. And I think Nicholas Timmins, who's a historian or kind of watcher of health issues, has previously observed that it has little impact within the health service or outside of it. So choosing to have a slightly more flexible mechanism where, for example, the Secretary of State, be they Jonathan Ashworth under a Labour government or the current incumbent under a Conservative one, to be able to introduce new incentives mid-year and additional political priorities, in our view, that is quite sensible. The decision to be able to move around responsibilities within each arm's length body, I can also see commanding Labour support. Were Labour to return as a majority in 2024, it's unrealistic but possible, they would presumably want to introduce a very bold policy agenda that would be divergent from the last administration. That could involve some quite big structural changes around the NHS. Say they wanted to do more ambitious work on prevention, and that might mean that they would want to take responsibilities away. So I think that Labour, whilst maybe batting on the opposing side in public, will actually secretly be quite supportive of a lot of what Matt Hancock is trying to do.
Thanks, Robert. David, your perspective, the private sector, the Labour Party.
Not for me, I suppose, to say what Labour thinking is or isn't. I just sort of point out the obvious, I suppose, which is looking at the statement that the Labour Party have made in response to the white paper. Comes back to a point I made in my opening remarks, which is in effect this mismatch between a sort of set of what the public may well see as fairly technocratic debates around the structure mainly of the NHS and to an extent its adjacency to social care, with the big ticket issues of the moment and for the next few years, which is access and workforce and mental health. And I think actually, there is scope, to continue to punch that particular bruise, because I do think the disconnect between those two things, you emerge from a pandemic and you say now is the time to legislate on the NHS. And if every time you're on the radio, you're asked the question, how does this help with access? It doesn't. How does this help with the workforce crisis? It doesn't. How does this help with the burgeoning problems within mental health? It doesn't. I think quite quickly the public will start to think, well, what on earth are you doing then? So that feels like a line that is being pursued. Clearly, as the legislation gets presented and the parliamentary process gets underway, there will be a debate about the particular proposals, and I'm sure there'll be areas of agreement and areas of disagreement. But the macro politics on this seem to me actually quite set. And I come back to those tensions I was outlining earlier on. That is one the government will have to be able to answer to when there is a lot of public interest in why it is that my family are waiting well over a year for treatment.
Yes. Robert, what's not in the white paper but should have been and might yet be moved as an amendment as a constructive criticism when the legislation goes through? What's the yawning gap as you see it?
I think we've talked about the yawning gap in social care quite extensively. I think one other thing that I would identify is we've talked about the lack of detail around some of the structures and how those will function. There's also some unanswered questions around big areas of NHS spending, such as specialised commissioning. So specialised commissioning, I think, is about 18 billion at the moment. And that's relatively tightly controlled within Skipton House. That will, according to the white paper document, the plan is to move a majority of that spend to ICS levels. But for example, that could have all sorts of challenges. They'll presumably want to keep some commissioning at a centralised level, for example, for the rarest diseases. So if you have spinal muscular atrophy, I think was the example that Simon Stevens used in his session yesterday, they'll obviously, there might only be a few hundred patients in England who suffer from that. So they'll want to make decisions centrally over affordability on things like medicines. But for conditions which are perhaps rarer, but not the most rare, I think there'll be an interesting conversation around how that budget is doled out, what the formula is and how that is designed. And then importantly, how that impacts on patient outcomes. Being able to control the budget centrally brings lots of drawbacks, but it does mean that there's ring fencing, and it means that decisions are taken neutrally away from local services. Whereas if you're an ICS lead with budgetary control, there could be that temptation to salami slice off one service that you think is less important to shore up another one. So that kind of comes back to David's point around cosy monopolies and just making sure there's enough independence and rigour in the commissioning process.
David, as one who worked for advising the Democrat front bench during the Lansley reforms, and I know Baroness Jolly is on our call with us today. The private sector was to move a couple of new clause amendments as the legislation emerges. What might they be? What gap would you like to see plugged?
So, I mean, I come back to the point about governance. I think that's probably the area that is weakest in the proposals. I think there's a deliberate reason to try and keep them weak, which is to say, well, let's let local systems sort of work this stuff out for themselves. I struggle to see, given they will be managing billions and billions of pounds collectively between them, that approach will hold. And I think holding the ring on the money, making sure that conflicts of interest are being managed, ensuring that the governance is strong and solid. It gives public confidence in the way in which that funding is being administered. And I think quite crucially as well, coming back to the point around plurality of provision, it gives voluntary sector providers, it gives independent sector providers and those who are not going to be holding the purse strings confidence that they can invest, they can participate in that local economy, and that they won't find themselves cast aside when somebody decides it's not in that particular provider's interest no longer to want to work alongside them. So that feels like the area that we would want to worry away at most as the detail of the legislation gets discussed.
Sharon, for your readers, what would Health Service Journals sponsor as a change to fill a gap?
I think it needs to be much clearer on accountability, who holds the money where. Things like we talked about conflicts of interest. We've had people coming to us saying that if a provider sits on the board making the decision about giving that provider money, how can that be viable? Then obviously you're just giving yourself cash. And I think that will come up more with the independent sector as well, because you can rightly query that and say, well, hang on a minute, why have you given, as someone sitting on X millions of pounds, why have you given it to yourself or not to another company? That's not being resolved. Speccom is a mess. I don't think that's going to progress very quickly. I don't think ICSs want it. And there's no governance structure whatsoever on how ICSs are meant to come together and work as an umbrella to manage this money. I mean, what would that look like? Is that another governance board? Do you need more legislation to enable that to happen? So I think accountability is missing. And I think within that, something around quality. So there's no real mention of CQC. They need to change their powers. They can't actually go and review any integrated care system without explicit permission from Matt Hancock. That was a surprise, that wasn't there. I don't know how they carry on doing their job without that. Again, around fit and proper person, you've got to have some mechanism of holding the chief executives and the chairs of the ICSs to account. That wasn't there. And I think around quality, we talked a lot about the money, the flow, how it will sit, but who is going to say this isn't good enough? Who's going to say you missed the quality on that because you're sitting on the same board? And I think maybe that's a little bit where the issue of patient voice comes in. And again, that's what's missing, because if you look at CCGs, they were too small. There was 212, they've now dropped down to about 100. They were too small. ICSs are too big to really capture the local need and the local voice. So what's going to sit in the middle? So I think the white paper initially sounded good, because it was going with the flow of where the NHS was going. It was, making concrete these ICSs that are in development already, but the holes are really evident. And I think there needs a lot more work around accountability and quality to make sure that what the taxpayer is paying for is actually delivered in a way that's equitable and safe.
Team, all our guests today, thank you so much for a stimulating discussion. We try and keep these pretty to the time limits, and we're on the right second for that. Thanks to our audience. There have been a couple of hundred of you taking time out to view this discussion, which is the first in our new series of Whitehouse webinars looking at this white paper and the legislation as they go through Parliament. We'll be putting the video of this up on our website, www.whitehouseconsulting.co.uk, and you're welcome to link to it yourselves or to have your colleagues watch it. So thanks to all our team, thanks to the technical support behind the screen, and we'll look forward to seeing you again. Thank you, panel. Goodbye.